All right, so let's talk about some genitourinary dysfunction in the pediatric population. Much of the information in this one is going to be brand new. We'll talk about urinary tract infections and things like that you would have talked about in med-surg in your adult classes, but much of this is pediatric specific, although it may be things you'll see into the adult population. They start in childhood, so that's why we focus on them here. First thing we're going to talk about is just diagnosis and assessment of urinary function. So some of the procedures we use, urinalysis, you already know what a urinalysis is, measuring things like your specific gravity, your pH of your urine. You have 24-hour urine collections to measure things like creatinine clearance. Then you have your solutes, like measuring your glucose and your ketones and your protein, measuring bacteria, all those things. So if you don't remember those values, I highly recommend you go back and review those, because you will be responsible from here on and forever knowing the normal values for a urinalysis and what you should expect to see. May do an ultrasound. Ultrasounds aren't just for babies. We do ultrasounds of all kinds of things in the body, and you can see ultrasounds such as the bladder scanner. Any of you that have used a bladder scanner, while you don't see a picture on a bladder scanner, it just gives you that volume of how much urine is held in their bladder. It works on kind of the same premise, using those sound waves. We can do CT scans, especially if you're looking at kidney disorders, biopsies, cystoscopy, cysto meaning bladder. So when we have a cystitis, we have a bladder infection. A cystoscopy is a scope where they place a camera up through the urethra to visualize the urethra, the bladder, possibly the ureters, whatever needs to be visualized. And then the one you see in the picture that you may or may not have ever heard of is called a voiding cystourethrogram, or voiding cystourethropography, the last one listed in the bulleted points. So what we do with this one, and I'll show you the normal versus abnormal a little bit later when we talk about urinary reflux, and that's what we're really testing for, is this is seeing if urine is flowing in the direction it needs to flow. So in this picture you see on the screen, that's an abnormal one. Ideally, that ball that's bright at the bottom is your bladder. And you see it's bright also coming up from the bladder. That is your ureter. Urine shouldn't be going up backwards through the ureter. So the process of doing this voiding cystourethrogram is they insert a Foley, and then they inject, or not inject, but infuse contrast dye into this through the Foley to put it up into the bladder. And they do this under fluoroscopy, so that like continuous x-ray, kind of like we watched with the GU when we were watching them reduce that not Hirschsprung's, but the intussusception. So when they put the contrast dye in, ideally it should stay in, and then they take the Foley out and they have the person void. Ideally, when they void, it should all go down. So only the bladder and then the urethra should be lit up on that fluoroscopy. As you see in this picture, it's not just the bladder that's lit up, but that ureter going, and you can even see the renal calculi and all, how they are lit up as well. And so that's showing that urine is flowing backwards instead of in one direction like it's supposed to. Other diagnostics we use as far as assessment is symptoms. So especially when we're talking about like urinary tract dysfunction, we talk about dysuria, meaning painful urination. DUIS meaning abnormal. In this case, it means painful. Frequency and urgency. That's something you often hear of as symptoms, especially with urinary tract infections. They are, when you have frequency and urgency, it means you constantly have this feeling like you got a void, even if nothing or very little bit comes out and you feel like you've got to go immediately. Then we have nocturia. You see that a lot in the elderly population, sometimes in children as well, where they just have, they get up a lot in the middle of the night to void. Enuresis, that's something you think of more with the peds population. You can have that with any, but that's your bedwetting. And then your polyuria, like you get with a diabetic, where they're voiding a lot. and your oliguria, oleo meaning little or very little, oliguria meaning they have very little urine output or no urine output. So the first thing we're going to talk about, most of this should be a review for you. Urinary tract infections really aren't that different in children than they are in adults. It is an infection somewhere in the urinary tract. Some of the terms you may hear that are all considered in the urinary tract family, your cystitis, which is a bladder infection, urethritis, obviously infection of that ureter, pyelonephritis, that's the more concerning one because that's where the infection has gone all the way up to the kidney and you have a kidney infection. Those kidney infections are more likely than a urinary tract infection to turn into that urosepsis because that's where your blood is getting filtered through. So it's more likely that it will get into the bloodstream and cause a systemic infection. And then your pyuria, which is your pus that's in your urine. So some symptoms, like I just mentioned about with assessment, looking for urgency, frequency, or sometimes in children where they're holding it. If they don't go for a long time, it might not be because they're dehydrated. It's because it hurts and they hold it. Children are very good at holding their urine when they want to. Some other things you might see is a strong smell to their urine. If it's a baby, a strong smell to their diaper. If they suddenly start having that enuresis or incontinence episodes, those could be signs of a urinary tract infection. Obviously, the pain with urination is something you think of as well. Sometimes their symptoms can be very subtle as well. When my daughter was 6 months old, she kept having these not very high fevers. They were low-grade fevers. Over a period of 2 to 3 days, they would kind of be intermittent, come and go. And she just acted like she just didn't feel well. So when I took her to her she happened to have a regular checkup scheduled in a couple days, and I mentioned the doctor. She's like, went through the typical questions, and that was one of the first things she thought about. She said, have you noticed her having any trouble voiding, acting like she's in pain? No. How's her diapers been smelling? And that's when it hit me. It wasn't an unusual odor, I guess you would say. It was just a very strong smell to her urine. And sure enough, when they checked her urine, she had a urinary tract infection. So that sometimes the symptoms are very subtle, especially in children. So in order to treat urinary tract infections, we do it the same way as we do in adults. We give them antibiotics. The most common ones you'll see, your sulfonamides or your sulfa drugs are a very common one, like your Bactrim. That's the trade name for that. Penicillins sometimes are used. I don't see them used very often, but especially when you have resistant bacteria, or if you have somebody who's allergic to, say, the sulfa drugs or whatnot. Cephalosporins usually is that second one you see most often, or your nitrofurantoin, which is your macrobid. Those are kind of the 4 big ones that you see for treating the urinary tract infection. The purpose of treatment is obviously you want to get rid of that infection because you don't want to disrupt that renal function, just like anywhere else in our body. When we talked about ear infections, those ear infections can cause scar tissue. So can urinary tract infections, especially if they're getting a lot of them or it goes untreated, and that can lead to permanent kidney, especially if it's a pyelonephritis where they have a kidney infection, that can lead to long-term consequences. And of course, obviously, you want to prevent that systemic spread. You want to prevent it from going into a sepsis or a massive systemic infection. So not only are we going to treat the urinary tract infection, but we want to, one, identify things that may have contributed to the situation and try and eliminate those. Like I mentioned, when my daughter was 6 months old, she got that urinary tract infection, and I'm sure they probably still do it. I know at that time as well, any child who under the age of 6 months got a urinary tract infection automatically got that voiding cystourethrogram, that BCUG, because one of the biggest contributors, which we're going to talk about in the next slide, of urinary tract infections in young children is reflux, meaning the urine is not flowing down. The sphincters that are supposed to cut off that ureter from that bladder and keep backflow of urine from happening don't close the way they're supposed to. So because of that, when the bladder contracts or squeezes to push the urine out through the urethra, you get backflow of urine up the ureters as well. And because of that stagnant urine sitting there as it's getting pushed back up, it can lead to those infections. So they automatically did a VCUG on her to make sure that wasn't what was causing it, because that's a common culprit of frequent urinary tract infections or early urinary tract infections. The other thing you want to look for is lifestyle methods that can contribute to urinary tract infections. This part, a lot of it you should already know. Things like making sure, especially girls, are wiping front to back, not back to front. Making sure that they are wearing cotton underwear, not like silk underwear that can't breathe. Wearing loose-fitting pants, we don't think about that, but tight pants don't allow breathability, kind of like the same thing with the cotton underwear. Fluid intake is probably one of the most important preventative measures for urinary tract infections, because if they're not drinking well, they're not voiding as frequently, and that kind of leads to that stagnant urine as well, and that's in adults as well. One big thing, though, that we see as a contributor, especially, it could happen in adults as well, but one big contributor we see, especially in children, is bubble baths. Because of the irritation, because of the soap that changes the pH around the urethra, it's a great contributor. We have parents all the time that would say, I don't understand why she keeps getting urinary tract infections. We keep her clean. We do all the important hygiene methods, and one of the first things when they say that is, well, I ask them, well, does she take bubble baths, or she or he? And more than likely, that's a lot of times the culprit when there's not other hygiene issues going on there. So those are all important methods to identify those contributors and hopefully decrease or eliminate those contributors to prevent those frequent infections. Generally, the highest population in pediatrics that you're going to see urinary tract infections in, number one, is girls, especially your under potty trained period. Once they get potty trained, usually the rate of urinary tract infections goes down significantly as long as there's no hygiene issues. And the second most common population is uncircumcised boys, because a lot of times the care is not, they're not appropriate hygiene methods are not used. And when you have a child, we're going to talk about phimosis, which can happen when that foreskin gets stuck, but or paraphimosis when it gets stuck, but with phimosis is where that foreskin is very tight, and actually under 12 months that's a normal finding. So it can be hard to clean between the foreskin and the penis under 12 months. So that's a big contributor of why uncircumcised boys have a higher rate of urinary tract infections than circumcised boys. So I mentioned one of the big culprits in children that we worry about with like I mentioned, one of the big contributors of urinary tract infections in younger children when there's no other culprits is VESICOURETERAL reflux, or a lot of times it's just referred to as urinary reflux. So what this is, like I mentioned before, it's where you have that retrograde flow, meaning backwards flow. So when those valves, as you see in the picture at the top, normally you have a valve or a sphincter that when the bladder contracts to empty, so that your urine goes out the urethra, when it contracts and those valves don't close the way they're supposed to, as it contracts, it's going to push it up as well. And we don't want it to go that direction, because then it creates stagnant urine. It can even push that urine all the way up to the kidney, and that's obviously a big deal as well. So when we have reflux problems, as you see, I mentioned I'd have two pictures. So the picture, the ones on the bottom of the fluoroscopy pictures, the one on your left is normal. You should see it just in the bladder and then the urethra below it. The one on the right-hand side is that abnormal VCUG, or voiding cystourethrogram. So you see it's in the bladder, but it's also going up that urethra even into the kidney. So that can become a big issue for these patients. So they often have those problems with urinary tract infections. A lot of times that is the first symptom noted to identify vesicoureteral reflux, is that urinary tract infection, or those especially frequent urinary tract infections. So treatment for this is what we call deflux surgery. And what they do is they basically inject that valve to make it fatter, so to speak, so that it closes better when it needs to. Oftentimes these children as well, if they don't have surgery, because sometimes they'll wait and see and it'll correct itself. Sorry. It'll correct itself, so they will put them on a low dose prophylactic maintenance level of Bactrim or your sulfa drugs. And this is to almost like they do with the sickle cell patients, how they're on penicillin as a low dose to prevent infections. They'll put them on a low dose daily Bactrim as a prophylactic preventative measure to hopefully keep them from getting urinary tract infections quite so much. So I mentioned phimosis, paraphimosis. So phimosis is where there is a narrowing of that foreskin opening. So in children or boys under 12 months of age, this is considered normal. You're not supposed to retract that skin all the way, that foreskin on especially newborns. As they get older, closer to that 12 months, you can gradually lightly pull on it to try and retract it, but newborns especially. So it can make cleaning and hygiene difficult. It's when parents aren't taught appropriate measures. So what happens if you force that full foreskin back, like you see in the picture on the right, is called paraphimosis. And this is where that skin actually gets stuck below the head of the penis. This is an emergency, because if it's stuck, then blood flow cannot get to the tip of that penis, and it could potentially cause cell death and tissue death. So this is an emergency if that happens, and that's why we don't retract that foreskin. You know, most people say the patients they hate to do a catheter on or a Foley on are women. I disagree. I think the population that I hate the most to do a catheter on is baby boys who are uncircumcised, because you can't retract that foreskin. So it makes it very hard to find that urethral opening. Sometimes you can retract it just enough to find the urethral opening, but there's a lot of times you can't even do it that far. So you're you're blindly trying to find it, and you often end up in between the foreskin and the penis. So two of the biggest things we worry about with phimosis is balanitis, and this a lot of times happens with inappropriate hygiene. We see this a lot in the pediatric population, where children will come in with pain, especially on urination, symptoms typical of a urinary tract infection, but their urine is normal, and a lot of times that's what they will go to if their urine is normal and they don't have any diagnostic signs of a urinary tract infection. Balanitis is that second option, and they'll usually instruct them to take Motrin and possibly steroids, things like that, if they need to, if there's a severe inflammation. But this is not a case where you need antibiotics for it. It's just inflamed, it's irritated. The other thing that's important about phimosis is not forcibly retracting any foreskin on any patient, whether they're a peds or adult. If it cannot be retracted with ease, it should not be forced, because if it gets stuck, that is an emergency. So another thing you see specifically in the pediatric population is called CRYPTORCHIDISM. Any of you that have boy children, you've seen where when they go for their regular checkups, they check to see if the testicles are in the scrotum. They start this from the time they're born. Ideally, those testicles should descend down into the scrotum at birth or shortly after birth, but for some reason in some boys it either gets stuck, either the tract to get because when babies are in utero, the fetus is in utero, it's still inside the abdomen. The testes are. So you want them to descend shortly after birth, but sometimes that tract where it should descend down into doesn't form correctly, or for whatever other reasons, it doesn't descend. The most common one is unilateral, meaning on one side. Usually it's very unlikely that it's going to be on both sides. The way they diagnose this is they feel the scrotum, and you should feel what feels like a little rubber ball in there. Because the testicles, no matter where they're located, even if they're still up in the abdomen where they're not supposed to be, they're still going to secrete hormones. So that is not an issue. Patients, if this is left unnoticed, for instance, throughout the years and they become teenagers, they're still going to secrete testosterone and all those growth hormones that they will have in order to reach maturity and puberty. But why we worry about it is because the abdomen is, and the whole purpose of having the testicles on the outside of the body, having the scrotum to allow the testicles to be on the outside of the body, is temperature control. If the testicles are left inside the abdomen, they're going to get too warm, and this can lead to fertility issues. Sperm cannot produce, or if it's produced, it can't live and transport past those vas deferens to get to where it needs and be a viable sperm sample. So you have issues with fertility is one thing that you would worry about, especially if it's a bilateral. That can lead to permanent infertility. But the biggest reason we worry about this, I found this out in practice. We had a child who had cerebral palsy, bedridden, unresponsive type of child. Definitely, it wasn't something you would be worried about as a fertility issue later on in life. They found out when he was a teenager, I believe he was 14 or 15, they realized he had an undescended testicle, and they were going to take him to surgery to take that out. And I was very curious about, why would you, not to be insensitive, why would you be concerned with that? And I found out, and this is definitely, there's a high risk of testicular cancer when that testicle is left in the abdomen. So that's why even in patients where they aren't worried about maybe fertility, they're still going to try and fix that, either to pull that testicle down into the scrotum, and they'll do what's called an orchiopexy, spelled ORCHIOPEXY. Pexy, when we're talking about surgical methods, pexy just means where you tack something into place. So what they do is they pull that testicle back down into the scrotum, and they basically suture it or tack it onto the wall of the scrotum, so that way it can't ascend back up. In this child's case, though, because it had been left in for so long in the wrong spot, they just removed that testicle. One, because he didn't need it for fertility purposes, but for two, because it had been left like that for so long, he had a very high risk of that becoming testicular cancer. So it's better just to take it out. So as you can see, there are a lot of potential disorders of the penis that you'll see. That's usually when we're talking about the genital area. It's more boys you see those disorders with than girls. Girls, you can have, I've mentioned this in class before, you can have labial adhesions where the labia are fused together, and it can be a little bit or it can be a lot, like I've seen it almost completely fused together. And usually with that, they'll use an estrogen cream to start with. Sometimes that will make the skin separate, but sometimes they will have to surgically correct it. But you do see more, especially notable genital defects in boys. So the last one we're going to talk about as far as genital defect is hypospadias and epispadias. So if you look at the picture on the top, normally the urethra should come out the end of the penis, the tip of the penis. When you have hypospadias, it comes out of the bottom of the penis. So instead of coming out at the tip, it comes out at the bottom. When you have epispadias, it comes out on the dorsal side or the top. So the ventral side is your hypospadias. Your epispadias is your dorsal side. So the bottom picture kind of shows you the different severities that it can have. It can be mild. It can be pretty close, especially if you have an uncircumcised boy, though. You may not realize that they even have this because they're still going to pee out of, the opening of the foreskin, but you don't know if that opening of the urethra is nearby or if it's further down the penis. So that's where this can become an issue if they're uncircumcised, not knowing. It can result in issues, especially when you have that tertiary type, the really severe type. Those are usually more noticeable even in a uncircumcised boy. So when it's a milder form, it doesn't usually cause any problems. They may do surgical correction later especially for physical appearance and your milder forms. But for your more severe forms, it can disrupt voiding, it can disrupt sexual function later on in life, so that's a big reason why they would correct that. One of the biggest things I want you to know, make sure you know, is that in these patients where hypospadias or epispadias, either one is suspected, circumcision should be avoided. And like I said, that could be difficult because you might not even know it's present until you go to do the circumcision, depending on the severity of it. But you want to avoid circumcision because when they go to do that surgical repair, which is generally done between 6 and 12 months of age, because they want the penis to get a little bit bigger and mature a little bit more before they do that, they avoid circumcision because they'll actually use that foreskin as part of that repair procedure. So avoiding those circumcisions is key to improve their outcomes of their surgery later on. So let's talk about the kidneys a little bit. We have two things we're going to talk about: nephrotic syndrome and acute glomerulonephritis, or AGN. You'll hear it abbreviated as. So nephrotic syndrome sometimes can seem to be idiopathic. With some children, they may have a viral illness ahead of time. It just varies. But a lot of times they have no idea what causes it. Usually the first symptoms that parents notice is where they'll start noticing the facial swelling especially, or the swelling of their legs, and weight gain. Remember, we've talked about one of the biggest indicators of fluid volume changes is weight changes. So a lot of times parents will notice they're getting quite heavy quite fast. So as far as the symptoms associated with this, they're going to have edema, and it's not just dependent edema where it's in their feet. A lot of times they'll get that periorbital and facial edema as well. They will get, for some reason, and I don't know the pathology related to this, they'll get the high lipids or the high cholesterol. They get low albumin, hypoalbuminemia. So the albumin, just a refresher back to med-surg, the albumin that's in your blood creates that osmotic pressure. That's important to keep fluid where it belongs. So specifically, when you have albumin in your bloodstream, that albumin holds the blood in your bloodstream. When you don't have enough albumin there, and that's where they get the swelling from. Because their albumin's low, the fluid is leaking out of their vessels because there's no albumin to maintain that osmotic pressure. So that's where they get the fluid leakage. So that's where they get the swelling. And because albumin is a type of protein, that's why they'll have proteinuria, high protein in their urine, is all that leaking of that albumin that they're putting out through the urine. As far as blood pressure, one of y'all asked me before in the ATI book, it says something about hypotension or low blood pressure. Every patient I've ever taken care of with nephrotic syndrome, and I have looked this up since then, have high blood pressure. I remember having a child one time, in fact, in step down, we had him on a antihypertensive medication drip because the blood pressure medicines orally were not maintaining his blood pressure, and he had to be on a blood pressure drip for a couple days. So I've never seen a child with low blood pressure from this. Normally it's very high blood pressure that you'll see with this, and I've looked this up as well to make sure that just wasn't an unusual case, and it should be high blood pressure that you're going to see with this. So diagnosis is based on their appearance initially, and then they can do renal function studies to see that what's going on, and they'll have decreased increased glomerular filtration rate. Sorry, that's a difficult word for me. Or GFR. They'll also do, when they do the blood lab studies, they'll see that the albumin is low. They'll see the protein in the urine. So those are things that will key them into this. Treatment is supportive, I guess you would say. Sometimes this can be a lifelong complication. Sometimes it does go away and they don't have continuing issues. Treatment for this is going to be steroids to decrease, because it is a type of like autoimmune reaction to something. Again, a lot of times we don't know why it happens, but it is that autoimmune type reaction. So they're often on steroids, and we'll put them on medications to get that extra fluid off of their body. So what we would usually do for these patients, you can't just give them LASIK. So again, review back to med-surg when we talk about third spacing or that extra fluid. When you have edema, that is third spacing. And what I mean by third spacing is you have fluid in places where it's not supposed to be, so your body doesn't recognize it's there. Like with edema, for instance, it's fluid in your body, but it's invisible fluid as far as your body looking at your intracellular and extracellular fluid. So what you have to do, if you just give them diuretics like Lasix or furosemide, all it's going to do is make them dehydrated because you're only pulling fluid out of their vasculature. And they're not fluid overloaded in their vasculature, they just fluid overloaded in that third spacing state. So what we would do is we would give them an infusion of albumin. Like I mentioned, albumin is the protein in our blood that creates that osmotic pressure. It'll help maintain the fluid in your vasculature. So if you give them an infusion of albumin, it will help by increasing the albumin in their blood, pull some of that fluid out of that third spacing. And then halfway through that albumin infusion, then we would give them a dose of Lasix or furosemide, because you've now pulled that fluid out of those third spaces. You've got to get that fluid in the vasculature before you can dump it off with diuretics. So we would give them that first and then give them the diuretics. So like I mentioned, therapeutic management of nephrotic syndrome is supportive care. You're going to do the best to maintain that renal function, prevent long-term complications. You're going to have methods to get off some of that fluid. They're often going to be on steroids to help decrease that overreaction of their body. A lot of times vaccination should not be administered during that time because of the steroids. It decreases their ability to actually react to those vaccines. Remember, the whole basis of vaccines and the way they work is you have to have an immune system to react to those vaccines to create that active immunity. If your immune system doesn't work because it's suppressed for whatever reason, chemotherapy, HIV, steroid use, long-term steroid use, there's no point in getting those vaccines because your body's not going to react to them. Positioning, don't forget positioning is very important when you're talking about a patient that is fluid overloaded and edematous. That skin gets tight. And when that skin gets tight, it's more likely to tear. We don't have as much issues with skin breakdown and all in your pediatric population like you do adults, but it is still can happen, especially in this case. So strict I's and O's with these patients. You need to measure every little thing going in, every little thing coming out. Those daily weights, don't forget, those daily weights are the best indicator of fluid volume shifts. So if they are gaining or losing weight a pound or two a day, pound or two every couple days, then that is significant fluid changes. Remember way back in, I think I talked about it in GU as well, but I know in med-surg it was talked about a kilogram gained is a liter retained. So approximately 1 kilogram change in weight is equivalent to a liter change in their fluid volume. So if they lose a kilo in a day, they lost a liter of fluid. Frequent urine monitoring, especially for that protein that's in their urine, you want to see, it can give you an idea of their status. If they start dumping more protein all of a sudden, or it's minimizing, it can show you the progress of their reaction. Abdominal girth, they can a lot of times get the ascites associated with that part of that fluid volume buildup. 2 important dietary measures: fluid restriction. They are very fluid restricted, as well as sodium restriction, because remember, where fluid goes, where sodium goes, fluid goes. So if you have if you have a lot of sodium in your diet, that can cause that fluid retention, which this is definitely a population we don't want that to happen in. Activity adjustments, a lot of times these patients have really bad fatigue associated with it. So you have to accommodate that. Make sure you're finding quiet activities for them to do to decrease that fatigue that they're going to have. So the last thing we're going to talk about is acute glomerulonephritis, or you'll often hear it abbreviated as AGN. So this is one of those strep complications that I was talking about before. Strep is an ugly little bugger. It can cause so many long-term complications if it is not treated appropriately. And again, these complications only happen in about 10% or have a risk in about 10% of the population. But that could be pretty significant, especially since these are significant complications that can affect you for the rest of your life versus just taking a 10-day course of an antibiotic to get rid of it. So what happens with acute glomerulonephritis is it usually occurs about 2 to 3 weeks after they've had a strep infection. And it could be maybe they didn't have an infection. Maybe it was a kid at school who had strep, or their sibling had strep, or they just got exposed to it and they never got the full-blown infection or symptoms that would make you actually treat them because you don't realize they're sick, but it still got into their body and their body still fought it off. So when we're talking about autoimmune reaction, or not autoimmune reactions, but autoimmune reactions, this is essentially what that is. It is where the body is fighting so hard against that strep infection. It's not the strep itself that causes it. It's our own body that causes it. So when it's fighting that strep infection, it gets a little too excited, and as it's being filtered through those tubules in your kidneys, it takes off little chunks, basically. And when it takes off those little chunks, it causes inflammation. Just like if you cut yourself or you scrape yourself, you get an inflammatory reaction. Same thing happens in here. So this results in, a lot of times they have hematuria and proteinuria, meaning they have blood and protein in their urine, and that's that really dark urine you see in the picture. So their urine will be very dark or even red, but a lot of times it's more of a brown, dark color. They often have edema as well as, and the hypertension. They get those same symptoms similar to that nephrotic syndrome as far as their blood pressure and their hypertension. The real big difference, I guess you would say, in nephrotic syndrome and AGN as far as symptoms is that lipids, the high lipids. You don't get this with the AGN. You also have decreased urine output with AGN. Another difference is this one is treated differently. Usually patients with AGN, they may be on steroids. In fact, often they will be on steroids, but they also, every patient I've ever had with this, they have had to be on short-term dialysis. So therapeutic management and treatment, again, you see it's very similar to nephrotic syndrome. They're often treated the same way. They have the same nutritional guidelines. They have the same strict I's and O's, daily weights, monitoring those vital signs. Like I mentioned, a lot of times these patients have to go on dialysis, and usually in the pediatric population, we don't do dialysis, especially in these acute situations. We don't do dialysis like you think of in the adult population, where you get dialysis 3 days a week and you go every other day. We do what's called CVVH, and this is done in the ICU. It stands for continuous venous hemodialysis. So they're hooked up to a machine that is continuously filtering their blood. It's not where they're put on for a few hours and taken off. The reason we do it this way is because it's less likely to cause those huge fluid and electrolyte shifts like you will get with your intermittent dialysis like we do in adults. So they'll do it more that way so that it acts almost like the kidney would. Very similar to, it's continuously filtering out that blood and getting out those things that aren't supposed to be there. Usually it's benign in the sense of it will resolve on its own. It's not a lifelong complication like your rheumatoid arthritis or your heart valve disorders you can get from strep, but it can be pretty significant, and it usually does last 2 to 3 weeks. So it'll start about 2 to 3 weeks after that strep infection, and it'll usually last 2 to 3 weeks. So they're in the hospital for a few weeks to monitor this, and a lot of times even when they go home for a while, the parents are instructed to maintain those nutritional guidelines and monitoring those weights and all that stuff. Rest with these patients, they also get fatigue, so rest is also important with them. So the last thing I'm going to mention to you is called a WILMS tumor or a nephroblastoma. This is one of the most common solid tumors in pediatrics. Leukemia is the most common cancer in general, but it's not a solid tumor because it's part of the bone marrow. So this is the most common solid tumor. A lot of times you see this in brain tumors. So this is where it buds off of the kidney. That's why it's called nephroblastoma. So a lot of times this is in the younger population under the age of 3, but not always. I have seen it 6, 7, 8-year-olds as well. And a lot of times the only way this is ever discovered is when they go to the doctor and the doctor feels a mass on the kidney when they're doing an abdominal palpation. Usually this does not have symptoms associated with it. It is where they're not going to have decreased renal function. I'm sure if it went on for a very long time without being caught, it could, but usually this does not have symptoms until it's noted. One of the most important things you need to know as a nurse with a WILMS tumor is that abdominal palpation is completely contraindicated once this tumor is noted. Now, the whole way we find it is through that abdominal palpation, but once it's identified, you must eliminate abdominal palpation. It is absolutely contraindicated because you could actually rupture that tumor, and you can imagine the complications associated with that.